What is the function of interleukin 4? If you do not know what is interleukin 4, please watch my last video of asthma pathophysiology. In there I have already mentioned what is the function of interleukin 4. Let me describe it here also. Interleukin 4 is stimulating the plasma cells just to produce immunoglobulin E. So if we block the interleukin 4, then we will not produce IgE, and if the IgE is not produced, it will block the mast cell and IgE complex, and histamine will not be released. So therefore the drug of choice is mepolizumab. You like the video, guys? Kindly share it to the needy ones so that everyone get an opportunity to encounter with the higher taste of knowledge. Let you all be the literary giant and let you blossom into the heightened possibility of yourself. Thank you, and again welcome to Neuro. Namaskar to all my dear friends, all my physiotherapists, all my nursing students and all my MBBS students. A very strong sense of gratitude to all of you from my side. Thanks for liking, sharing and subscribing the YouTube channel. Thank you very much. So, in our last class, we have discussed about the topic asthma. What is asthma? I have already mentioned in our last class that asthma is a chronic inflammatory disorder which is causing bronchoconstriction and airway hyperresponsiveness. So, let me summarize our last class. So, first of all, what was actually occurring over there, that pseudocolumnar epithelial cell was releasing T lymphocytic protein, thymus stromal lymphocytic protein. That thymus stromal lymphocytic protein is stimulating the dendritic cells to activate. That dendritic cell attract with the help of chemoattractants, just bringing the T lymphocyte, T helper 2 cells from the blood vessels to the lungs with the help of chemoattractants. That T helper cells, when come in the lungs, then that T helper cells was releasing interleukins. That interleukins, such as which interleukins was? That interleukin 13, interleukin 4. Interleukin 13 and interleukin 4 was stimulating the plasma cells just to produce the immunoglobulin E, that is IgE. That IgE was just combining with mast cells, and from where mast cells come? The T lymphocyte, the T helper 2 cells was inducing interleukin 9 just to stimulate the mast cells production, and mast cells are found in the lamina propria of the histology of an airway. So, increase in the production of mast cells and increase in the production of immunoglobulin E, they both together combine to form IgE mast cell complex, and that IgE mast cell complex was releasing histamine to cause bronchoconstriction. So, the main classical sign was bronchoconstriction. So, let me summarize the clinical manifestation of our last class. If you didn't watch the asthmatic video, kindly go to my channel playlist of respiratory and just click on the asthma video and just check it out the video. Thank you, guys. Now, let me summarize the clinical manifestation of our last class. The clinical manifestation of our last class of an asthmatic lung was dyspnea. Why dyspnea? Dyspnea because of the bronchoconstriction. Due to bronchoconstriction, histamine release, bronchoconstriction was occurring, and due to this bronchoconstriction, difficulty in breathing is called as dyspnea. The next clinical manifestation was chest tightness. The patient will complain about that his chest is tight during inspiration, and the next one was important one, nocturnal worsening. Nocturnal worsening So let me explain what is nocturnal worsening. Now in nocturnal worsening, what was actually occurring when the patient is exposed to the night. Why night? Because in night what actually occurs that we get exposure with the cold air. The climate of night and early morning is very cold. In natural conditions, in cold conditions, natural tendency of our airways is just to bronchoconstrict. And because of that bronchoconstriction, what is actually occurring in asthma also, there is already bronchoconstriction due to the release of histamine. But here, what is actually occurring? When he get exposed with the night, so again another bronchoconstriction just add on, and that bronchoconstriction is causing worsening of the signs and symptoms and the conditions of the patient. So this is termed as nocturnal worsening. So let me tell you about another important one, eucapnic hyperventilation. What is eucapnic hyperventilation? In eucapnic hyperventilation, when we expose the patient to cool air such as AC, air conditioner, so what will actually happen? The bronchoconstriction will occur. I already mentioned at this point in nocturnal worsening. In eucapnic hyperventilation, what is actually occurring? The patient is getting exposed or encountered with AC, air conditioner or a cool air. So that is resulting in the eucapnic hyperventilation. Hyperventilation means the tachypnea will occur and the patient will get irritated. So this is termed as eucapnic hyperventilation. One more thing to add on, NCLEX special, AIMS special. Just note it down, guys. Pulsus paradoxus. Pulsus paradoxus. This is also a clinical manifestation of asthma, but when is the main point to remember. So this is my NCLEX special of the class. NCLEX special or AIMS special of the class. Pulsus paradoxus. In pulsus paradoxus, what is pulsus paradoxus? Let us see. When the patient will inspire, then decrease in the systolic blood pressure more than 10 mm of Hg. Means in pulsus paradoxus there will be the marked decrease in more than 10 mm of Hg, and when? During inspiration. So in inspiration there will be the marked decrease of systolic blood pressure in the inspiratory conditions. This term is termed as pulsus paradoxus. So this is the classical one, the important one from the NCLEX special. This is the AIMS special. Now let us see. Today we will talk about diagnosis of asthma. That how will you diagnose the patient of asthma? So before diagnosing the patient, let us differentiate between asthma and COPD. That what are the basic differences between asthma and COPD? Differential diagnosis, I mean to say. So this is the patient of asthma and this is the patient of COPD. What is the basic difference between an asthmatic or a COPD patient? First difference. An asthmatic patient may or may not be a smoker, but a COPD patient is always a chronic smoker. Another difference, asthma occurs in episodes. Episodicity means there will be short episodes of asthmatic attack. Bronchoconstriction will occur, and due to that bronchoconstriction, dyspnea and chest tightness will occur. And why bronchoconstriction? Due to the histamine release, due to the formation of mast cell and IgE complex. But in COPD, progressive, slow and persistent worsening of condition will occur. Okay, now third difference, hyperinflation will occur definitely because air trapping is occurring here also. Why air trapping? Suppose this is your bronchi and this bronchi got bronchoconstricted, so the air will trap, and due to that air trapping, hyperinflation will occur in asthmatic condition also. But in COPD also both same condition, same term, hyperinflation, and we will add one more thing here, flattened diaphragm. In chest X-ray we will see flattened diaphragm. In the chest X-ray we will see in the condition of COPD. Next one, the total lung capacity will increase. Here also the total lung capacity will increase. Here also in COPD also total lung capacity will increase. Why total lung capacity is increasing? Because of that air trapping, hyperinflation of the lungs is occurring, and due to that the total lung capacity, that is normal total lung capacity, is 6000 ml. So more than 6000 ml will be occurring in the condition of COPD. Next one, let me delete it. Fifth one, major difference, this is asthma and this is COPD. Fifth one, the fifth difference between asthma and COPD is that PO2 is decreasing, but PCO2 increases. Not increases, it will remain normal. PCO2 will remain normal. But in COPD, PO2 will decrease and PCO2 will also increase, not decrease, increase. PCO2 will increase in the condition of COPD. Now, sixth point, this is the fifth one. Sixth one, so there are some similarities and there are some difference. Sixth one is that in asthmatic condition, infrequent infrequent sputum, important one to diagnose, important one, NCLEX special. How will you differentiate between an asthma and a COPD patient? Because there are similarities between the sign and symptoms, but how will you differential diagnose the patient between the asthmatic patient or a COPD patient? Infrequent sputum, but with eosinophilia. Eosinophilia means increase in the production of eosinophils. And why eosinophils? Due to the stimulation of interleukin 5. That interleukin 5 is stimulating the bone marrow to produce eosinophils, and with the help of dendritic cells, the chemoattractants are attracting the eosinophils from the bone marrow towards the lungs, and the mucus in the sputum we will see eosinophilic finding in an asthmatic condition. But in contrary to it, in contrast to asthmatic patient, in COPD what will actually happen? This is the sixth one. What will actually happen is productive tenacious means sticky sputum frequently seen means in regularly we will observe the production tenacious sputum. So these are basic similarities and differences between an asthmatic patient and a COPD patient. Now let me describe the diagnosis of an asthma. How will you chiefly diagnose the patient of COPD and asthma? We will talk here about, we will give more energy here, invest our energy here on asthmatic patient. See, when I said to a COPD patient, first of all let us see about COPD patient. What is the basic difference? I will say the patient to do not take, let me make you more clear, just note it down. I will command my patient to not to take bronchodilator 6 hours for 6 hours. Do not take bronchodilators. Do not take bronchodilators. I will command my patient. But bronchodilators. But after 6 hours, I will say my patient to forcefully expirate. I will do the spirometry test. After 6 hours, I will tell my patient to forcefully exhale. So, suppose the FEV1, I also mentioned in my COPD class that what is FEV1. If you do not know what is FEV1, kindly go to my COPD video in the playlist of NeuroHerb, respiratory playlist of NeuroHerb 21. You can watch it there. So now I will again explain it. What is FEV1? FEV1 means forceful expiratory volume in 1 second. 1 denotes in 1 second. So I will tell my patient to exhale forcefully. So when I tell my patient to exhale forcefully before taking the bronchodilators for 6 hours, prior taking to the bronchodilators for 6 hours, then what will happen? Suppose the FEV1 value after is Y. Suppose, or we can say that X. First of all, again let me explain. I am saying my patient do not cross, do not take what? Bronchodilators before spirometry. After spirometry, suppose the FEV1 value is X. Now I am saying my patient take bronchodilators. I will say my patient, I will command my patient to take bronchodilators after the FEV1 value. Then what will happen? There will be no increment of FEV1. Note it down, guys. In COPD, there will be less increment or no increment of FEV1 value in COPD after taking the bronchodilators. After taking bronchodilators, decrease increment or no increment of FEV1 means, let me summarize it here, we will not give the patient bronchodilator 6 hours prior to the spirometry, but after once the spirometry value is FEV1 value is suppose X, but after administration of the bronchodilators, suppose the FEV1 value remains X or some part increase, less increment of FEV1, this condition shows irreversibility. This condition shows irreversibility, and this irreversibility is confirmatory diagnosis. This FEV1 do not increase, we can say that no increment of FEV1 shows irreversibility, and this irreversibility is termed as COPD condition. Now, suppose in asthmatic patient, I will just do the differential diagnosis, that how will you confirm that this is a patient of asthma and this is a patient of COPD. Got it? So, in the asthmatic condition, I am saying my patient do not take bronchodilators. What are the bronchodilators? SABA and LABA, short acting beta 2 agonist, that is salbutamol, terbutaline, and long acting beta 2 agonist, that is salmeterol, formoterol. So I am saying the patient do not take bronchodilators 6 hours for 6 hours. But after 6 hours, what I will do is spirometry. And what will be the finding? Suppose the finding will be the spirometry FEV1. What is FEV1? Forced expiratory volume in 1 second. The finding will be X. Suppose the finding will be X. Now I am saying my patient to take, I will provide bronchodilators, that is salbutamol or salmeterol, formoterol, anything it may be. So after providing bronchodilator, if note it down, mark it down, NCLEX special, AIMS special, if after, yeah, post administration we can say. The technical term will be post administration. Post administration of bronchodilator, the FEV1, suppose if the FEV1 increased by 200 ml or greater than 12%, then this condition, in COPD condition, FEV1 is not increasing. This is showing the irreversibility. In COPD, irreversibility is shown, but in asthma, there will be reversibility. Why reversibility? Because there will be the increment of FEV1 more than 200 ml or 12%. This shows reversibility. Reversibility. And this reversibility confirms the condition of asthma. This is the confirmatory diagnosis of asthma. I hope you will like this. Note it down, guys. Mark my words. Note it down on your notebooks. So what will be the diagnosis? I am summarizing it here, that the FEV1 ratio will be X plus 200 ml, more than 200 ml increment in the FEV1 post administration of bronchodilator. This is the diagnosis, first diagnosis of asthma. Now the second diagnosis will be eucapnic hyperventilation. I already mentioned. What is eucapnic hyperventilation? The patient will be exposed to an air conditioner or any cool condition or any cool air, then there will be hyperresponsiveness, and if the hyperresponsiveness occurs, then this condition is termed as, this is the confirmatory diagnosis of asthma. Now the third diagnosis will be chest X-ray. Chest X-ray HRCT will be not more significant, because in COPD also hyperinflation is occurring, and in asthma also hyperinflation is occurring. So there will be no relevance of chest X-ray. We will find it out on the basis of FEV1 only. Another chest X-ray will reveal hyperinflation. Chest X-ray will reveal hyperinflation, and one more thing, last but not the least, sputum. Sputum will show eosinophilic infiltration. So this is the basic diagnosis of asthmatic condition. Now we will talk about the classification of asthma and the treatment of asthma. Now let us see. Let me delete it, note it down. So, classification of asthma. What are the classification? So basically, asthma is generally classified into 4 types. The first one, intermittent asthma. Intermittent asthma. What is intermittent asthma? That the episodes of asthma comes intermittently, means not generally but sometimes, rare cases. How it will be classified? If the sign and symptoms occurs less than 2 days, in a week, the sign and symptom is seen less than 2 days a week, then this asthma is termed as intermittent asthma. Second asthma. If this asthma is mild, persistent asthma. If the sign and symptom is greater than 2 days, the episode of asthma comes greater than 2 days per week, then this type of asthma is termed as mild persistent asthma, 2 days per week. The third type of asthma is moderate persistent asthma. Moderate persistent asthma. What is moderate persistent asthma? If the sign and symptom, if the episode of asthma comes daily. What do you mean by daily? Daily means at a certain period of time, mostly at night. Or early morning, mostly at night and early morning. That type of asthma is moderate persistent asthma, because episodes are coming daily. This is the important point to remember. NCLEX special. Next one, if the episode of asthma comes daily and the frequency of asthmatic episodes is greater, means throughout all the day, and night, then that type of asthma is classified as severe persistent asthma. That means throughout the day and night, what is happening, the frequency or the exacerbation of asthma is occurring. That type of asthma is severe persistent asthma. And last but not the least, very severe persistent asthma. It means if the frequency throughout day and night, but frequency will increase. What do you mean by frequency? Frequency is increasing. What do you mean by frequency? Means suppose an asthmatic episode comes at 7:30 am. Okay, then after 10 minutes it comes, after 1.5 hours, after 1.5 hours again it comes, after 2 hours again it comes. The frequency of an asthmatic episode, if increases throughout whole day and night, the patient will suffer more, and this is the last stage of asthma, that is very severe persistent asthma. That means throughout the day, increase in the frequency, the asthmatic episodes will come. Now let me talk about the treatment of asthma. Note it down, guys. Suppose in intermittent asthma, what will be the treatment of choice? We know in asthmatic condition, bronchoconstriction was the main thing, main symptom. Bronchoconstriction with the main sign. So, first of all, we will treat bronchoconstriction. We will treat the symptom. We will treat the symptom with long-acting beta 2 agonist, that is formoterol. But with the help of formoterol, we can only treat the symptom. Because what is actually the mechanism of action of LABA, a long-acting beta-2 agonist, formoterol, is just it will bronchodilate. For some time it will bronchodilate, but here in the pathophysiology of asthma, I already mentioned that Th2 helper cells, suppose this is Th2 helper cells, this Th2 helper cells, what this Th2 helper cells are doing, that this T helper 2 cells releasing various cytokines, and suppose interleukin 9 is producing mast cells, and interleukin 4 and interleukin 13 is releasing IgE. And with the help of IgE and mast cell complex, IgE and mast cell complex, histamine is releasing, and this histamine is doing bronchoconstriction. So we are only treating this bronchoconstriction by LABA. We are only treating this bronchoconstriction with the help of LABA, long-acting beta-2 agonist, that is formoterol. But we are not treating the main root, because this Th2 helper cell will again release interleukin 9 that will induce the mast cell production, will again release the interleukin 4 and 13 to induce the IgE production. For that, what we have to do? We have to just treat the root. How will you treat the root? Just to inhibit this Th2 helper cells. How will you inhibit the Th2 helper cell? By only giving inhaled corticosteroid, that is budesonide. Inhaled corticosteroid, budesonide, and long-acting beta agonist formoterol plus will be the treatment of choice in the intermittent asthma. Let us make it more clear. This inhaled corticosteroid is inhibiting this T helper 2 cell, the root cause of bronchoconstriction, because it is releasing interleukin 13 and interleukin 4 to stimulate the IgE production and mast cell production. So we will treat the root cause. And how will you treat the root cause? By inhibiting the T helper 2 cells. So let me make it the more clear. What will be the treatment of choice in intermittent asthma is is long acting beta agonist plus low dose ICS, that is formoterol and budesonide. This will be the treatment of choice in intermittent asthma. And what is intermittent asthma? I told you less than 2 days. The episode will come less than 2 days per week. This will be the treatment of choice in asthma. Now, we will talk about next classification. Second one. That is mild persistent asthma. Mild persistent asthma. In mild persistent asthma, I already mentioned the episode of asthma will be greater than 2 days. More than 2 days, episode of asthma will be more than 2 days per week. What will be the treatment of choice? Let us see. The only treatment of choice is ICS in low dose. Inhaled corticosteroid in low dose. That means budesonide. Only budesonide we will give. This is the treatment of choice in the mild persistent asthma. Now, let me delete it. So, third one, moderate persistent. Moderate persistent asthma. That means, what was the classification of moderate persistent asthma? The moderate persistent asthma means the episodes of asthmatic attack is coming daily and especially at night or in the early morning. So, what will be the treatment of choice? Again, low dose ICS, inhaled corticosteroid, that is budesonide, AIMS special plus LABA, long acting beta agonist, that is formoterol. Okay, but daily. Special point to remember, here we will give this drug daily. I already mentioned low dose inhaled corticosteroid and long acting beta 2 agonist in the intermittent asthma also. I mentioned it in the intermittent asthma also, but there in intermittent asthma we will provide low dose inhaled corticosteroid and long acting beta agonist when needed. There we will provide these two drugs when needed only during the episode, but here we will provide low dose inhaled corticosteroid and long acting beta agonist budesonide and formoterol daily, on the daily basis. Why? Because here the severity of asthmatic episode is more, because all the night the patient will suffer during the asthmatic attack. Okay, so here we will provide low dose inhaled corticosteroid and long acting beta agonist. Now the fourth one, the fourth one severe persistent asthma. Severe persistent asthma. So what will be the treatment of choice in severe persistent asthma? And what is the classification of severe persistent asthma is throughout the day and night. Throughout day and night. This is the classification. So what will be the treatment of choice? Let us see. Medium dose. Medium dose ICS, that is budesonide plus LABA, long acting beta agonist. Here also daily we will provide it, these two drugs daily, but there will be marked difference. The difference is medium dose, the dose will increase in severe persistent asthma. Last but not the least, very severe persistent asthma. Here we will provide high dose inhaled corticosteroid, that is budesonide plus long acting beta agonist, that is formoterol daily. The dose will increase. Plus one more thing to add on, that is plus one more thing we will add here, that is add-ons. Means we will add other drugs. And what will be the other drugs? Let us see. So this high dose inhaled corticosteroid, that is budesonide, we will increase the dose of budesonide, and long acting beta agonist, that is formoterol, plus add-ons. Now I will talk about add-ons. What are the add-ons? Let us see. Add-ons. We will add on first. Anticholinergic. And the treatment of choice of anticholinergic is tiotropium bromide. We will add on one more drug, anti-IgE monoclonal drug, that is we will provide here in very severe, we will provide high dose inhaled corticosteroid plus long acting beta agonist, that is formoterol, plus we will add on some drugs. Another drugs will be, first of all it will be anticholinergics, that is tiotropium bromide, and anti-IgE monoclonal drug, that is omalizumab. And this omalizumab will be provided it subcutaneously. And what is the mechanism of action of this omalizumab? This omalizumab will inhibit the IgE production. And why IgE is producing? IgE is producing by inducing of interleukin 4 and 13, and that interleukin and 4 and interleukin 13 is inducing the plasma cell to produce IgE, and this IgE will be blocked by omalizumab, and this will be in the form of subcutaneously. It is given subcutaneously. Now third one, interleukin 4 inhibitor. Mepolizumab. And interleukin 4, what is the function of interleukin 4? This you have, if you do not know what is interleukin 4, please watch my last video of asthma pathophysiology. In there I have already mentioned what is the function of interleukin 4. Let me describe it here also. Interleukin 4 is stimulating the plasma cells just to produce immunoglobulin E. So if we block the interleukin 4, then we will not produce IgE, and if the IgE is not produced, it will block the mast cell and IgE complex, and histamine will not be released. So therefore the drug of choice is mepolizumab. And last but not the least, interleukin 5 inhibitor, which will inhibit the eosinophil count, and the drug will be dapulizumab. I hope you like the video, guys. Kindly share it to the needy ones so that everyone get an opportunity to encounter with the higher taste of knowledge. Let you all be the literary giant and let you blossom into the heightened possibility of yourself. Thank you, and again welcome to NeuroHub 21.